Welcome to the Health Channel, all health, all the time. I'm Kathy Buccio, coming to you from the Baptist Health South Florida studios. Today we're talking about a disease that is arguably the one women fear the most, breast cancer. In fact, 1 in 8 women are diagnosed with breast cancer. It's the #1 cancer in women and the #2 cancer killer of women. And joining us today to talk about breast cancer, what it is and who is at risk, is Dr. Victor Guardiola, a medical oncologist at the Miami Cancer Institute. And what great timing, because October is actually Breast Cancer Awareness Month. I see you representing with your tie. I wear my dress today. Thank you for being here.
Thank you. It's an honor for me to be here, particularly in this month, and thank you for the invitation.
And it's so scary to think 1 in 8 women are diagnosed with breast cancer. I mean, is early detection the key?
I think so. As I said, the frequency, being 1 in 8, you just said it, makes screening, early detection a must. I think we have enough years of proving that early detection, meaning before you feel a symptom, before you feel a lump, if you can detect something very early, you're saving yourself from very aggressive treatment, #1. #2, doing it this way has shown to save lives. So for us, early detection is key, and this month in particular is all about make awareness, early detection, mammograms, and then obviously breast examinations, and call your doctor right away if you feel something.
And it all starts with you, correct?
Yes, absolutely.
It all starts with you. Now, each year, breast cancer claims the lives of those we love. However, as we just mentioned, when it's detected early at a localized stage, their survival rate is 98%. So let's take a look at this video from the breast cancer survivors who say early detection saved their lives.
I was too young to get a mammogram, and I had no family history, and the lump was probably just nothing.
And I sat in that waiting room talking to women, and there were about 10 of us, and I casually joked with another woman, I can't believe that 1 in 8 women will be diagnosed in breast cancer. There are 10 of us in this room today.
Yo sabía que iba a regresar positivo.
I insisted on getting a biopsy.
When I heard my grandmother was sick, I knew I had to take care of her more instead of her taking care of me.
I heard the 3 most horrific words anybody could ever hear. You have cancer.
My initial reaction when I was diagnosed is, I'm gonna die. Oh my goodness, I'm going to die, and I'm gonna leave my 2 young daughters behind.
I had a 4 and an 8-year-old and a husband to grow old with. And I didn't think that I thought my life was over.
Cuando tuve que llamar a mi mamá, ahí fue real.
If it comes back and you've done everything you can, at least you can turn to your boys and say, I did everything I could.
And so a couple weeks after my diagnosis, I had a double mastectomy.
They were giving me life-changing, devastating news, but at the same time, they were giving me a plan. Okay, this is what we have. This is how we're going to treat it.
I felt very blessed to be here in Miami and to have a network of doctors.
Cancer treatment is ugly. The way Baptist treats you as a person is beautiful.
When you finish radiation, you ring a bell. Pretty much the entire staff of MCI showed up.
I just knew in my gut that I was going to be okay.
Your dream team is out there.
Escogimos un team divino. Las siento como unas personas, como amigas, más que doctores.
If I waited, I wouldn't be here today. Early detection is incredibly important. Know your body. Go into your doctor, get the mammogram, get checked.
I can't stress enough how important it is to be your own advocate.
Early detection saved my life. Embrace tomorrow.
Programe su mamografía hoy.
Abraza el mañana.
Schedule your mammogram today.
What a powerful, powerful video. And I think it's also, you hear these women's inspirational stories, and I think everyone has a connection to someone that has had or has breast cancer. And It was so shocking to hear one even say that she wasn't even old enough to have a mammogram, and here they are. When you see this video, and see these survivors,
Yeah.
what do you think? What goes through your mind?
So yeah, what goes into my mind is like how early you have to start to be checking yourself for a disease of such nature, and so it comes down to, thank God, statistically speaking, cases of less than 40 years of age and being diagnosed with breast cancer are very few. It's believed to be less than 5%, but still the fact that we have about 260,000 new cases of breast cancer, if you do the math, you're still talking about 10,000, 12,000 young females before the age of 40 that suffer from this. And here's the controversy on when to start, the best screening tool, which is mammography, right? And that controversy radicates in between the safety of doing it, which is, I think, is safe, but it has its own cons of doing it, and it has to do with is it worth it? Is it worth it to start with a screening tool, at the age of 25 or 30, for example? So
Because there is controversy as to the guidelines as to how early these exams need to happen, or these screenings need to happen.
Absolutely. So yeah, so 2009, the U.S. Preventive Services Task Force came up with a conclusion based on analysis of data that it wasn't necessarily worth it to do it below the age of 50. And the American Cancer Society, for example, recommends 40 to 44 to be pretty much an independent decision.
Right.
And then, but we believe that at 40 everyone should, at a normal risk, right? At a high risk, you should start early.
Now, what are some of the symptoms that women experience when they have a breast cancer?
So often than not, because the technique of screening has become widely available, is usually that the patients do not feel anything. And so that's
Really?
the reason, yeah, the main diagnosis comes after an abnormal mammogram. And that's the reason for the shocker, right? So you go for your screening mammography, and then you're found to have an abnormality that requires a biopsy, and that's how we ended up diagnosing breast cancer. But
at this point, a patient comes in because they're feeling something, so they
Exactly.
want to go in and get an MRI, and they want to go in.
Exactly. So then there's the group of patients that actually feel something, and arguably the ones that are usually below the age of 40, where there's no screening mammography going on. The most common finding is a lump.
Right.
It's a painless lump. That doesn't mean that it's a sole abnormality that should make you seek attention, right? So any changes in your breast, and that's the reason why self-recognition of your own body, I think, is important, is vital. Like changes in the color of the skin of your breast, nipple changes, nipple inversions, scaliness of the nipple. These things are not necessarily normal.
Right.
That doesn't mean that it's going to be breast cancer, but at least you have to start by talking to your doctor about it.
Now, what about fibrocystic lumps? Are those often confused for a lump that could be cancerous?
Yeah, so fibrocystic lumps, or also fibroadenomas or benign cysts, are not necessarily confused by providers with cancer, in the sense that if you go through the diagnostic workup, we can tell you and rest assure you that these are benign conditions, but getting to be 100% sure that those are benign just based on a physical exam sometimes is tricky. So although we have some guidelines, like the harder the lump, the less mobile it is, the more suspicious it's going to be. That doesn't mean that a softer, rounded structure could necessarily be a normal benign tumor. So have it always checked.
Now, Dr. Guardiola, I want to jump right into the risk factors of breast cancer, and we can go over some of these. What are the risk factors that are associated with this type of cancer?
Yeah, so we have here, as obviously getting older, we know that, as I mentioned before, only less than 5% of breast cancer cases will be diagnosed before the age of 40. Genetic mutations. So this is another big question that arises all the time. Should everyone with breast cancer be genetically tested? And the answer to that is obviously no. By virtue of, thank God, only 5% of the cancers are usually genetically driven. The vast majority are not. So early menstrual periods, late or no pregnancy, that has to do with spending a longer life with estrogen-driven years. So every
Right.
time that you get a pregnancy, you breastfed, you lessen the amount of estrogen your breast tissue is exposed to. So obviously late menopause will carry an estrogenic life a little bit longer.
Right.
And then things like being physically active, obviously being obese, having dense breasts, also having associated as a risk factor.
What is a dense breast?
So dense breast is, we currently have a category developed by the American College of Radiologists of trying to classify the breast based on mammogram findings in 4 categories. So the lesser the breast density is, means that it has more glandular tissue, more breast tissue, and it's easier to pick up abnormalities. the denser the breast gets, the more I would say soft tissue that is not breast
Right.
herself has in there, and it's very difficult because you ended up seeing a shadow on the mammogram, and you cannot set things apart sometimes.
Now, we see things as birth control pills that contribute to higher risk.
Yes.
Family history of breast cancer.
Yes. So family history has statistically shown obviously to carry a risk, some through genetics that we know, and some through other things that we do not know. So clear things like BRCA1 gene mutations, BRCA2 gene mutations, PALB2 mutations. These are known genetic risk factors, but sometimes you find families that carry breast cancer risk, and not necessarily we can detect a genetic test that can prove it.
And also there's non-cancerous breast diseases as well.
Yes.
That can lead to breast cancer.
Yeah, so what some other non-cancerous breast conditions, for example, just to name one, atypical lobular hyperplasia, that's something that you ended up finding on a biopsy after an abnormal mammography, often than not, carries a statistical risk of more chances of developing breast cancer. Not necessarily to the extent of, let's say, someone that has a genetical driver like BRCA mutation, but enough for us to be in a high-risk screening modality, which is a little bit different than your average risk of 1 in 8, as you mentioned, in a lifetime of developing breast cancer.
Now let's talk about the abnormal breast cancer genes. Some you mentioned, some we're very familiar with. They shed a light. Angelina Jolie had the BRCA1, and I think people started talking more about it. Then we had BRCA2, and we have PALB2. So what are these genetic these strands that you're talking about?
So yes, so when we talk about genetic mutations, what we're talking is what we know so far. So as far as genes is a small, very tiny component of your whole DNA structure. It's what makes you. So there are certain genes that we know if you ended up having a mutation, that carries enough risk for breast cancer and some other malignancies for you to consider action.
Right.
Action in prevention more so than early detection. Also early detection as well, but to be thinking about how can we prevent this mutation from becoming cancerous again. Now, knowing it all, I don't think we're there yet. So there is the environmental factors. There are other genes that we don't know. There's connection between genes that we don't know. So that doesn't mean that if you test genetically negative, that we can rest assure you that you will never have breast cancer. And the opposite is true too. Not everyone that has the mutation means you're gonna have cancer. It's just that the risk goes higher.
But now, why is it that some women get tested and they find out they have these genes and they have a high risk for breast cancer, and then they decide to do a double mastectomy?
Yeah, so obviously, since cases like Angelina Jolie that have made this more publicly available, there's more consciousness about doing what we call risk reduction surgery. So get a double mastectomy before the event of cancer. And that has led to pretty much not hearing from that event before to now all of a sudden everyone wants to get it done. And so where do we find the middle term? And I think the recent statistics shows that actually, for example, for breast cancer survivors that can get away with just either a unilateral mastectomy, so the site affected only, or a lumpectomy, often than not chooses to do double mastectomy not to deal with the problem ever back again.
Right.
And I think it's our job to actually educate and provide the tools statistical tools that proves that in most cases you don't necessarily need that, even if you're a breast cancer survivor.
Right.
But obviously, this has to be in consideration with the patient's wishes, right? If they don't want to hear of a mammography ever back again, they don't want to just go through, obviously, the whole process of screening back again, then certainly that should be considered.
Absolutely. Now, coming up, a breast cancer survivor is going to be joining us on set. We'll hear her story and her journey in the fight against breast cancer, so stick around. You're watching the Health Channel, all health, all the time, on South Florida PBS. If you have a question for Dr. Guardiola, please call in using the toll-free number 855-796-4475. And please be sure to visit our website, allhealthtv.com, where you can watch videos from previous episodes or submit questions for the experts. I'll be right back.
A smile. It can show how we feel. It can change the course of our lives. But what would life be like if you weren't able to smile? It doesn't have to be this way. Since 1999, Smile Train has been helping children experience the simple joy of a smile. To learn more, call or go online now.
It is the most amazing gift that you can give someone. You're seeing individuals have an opportunity of their lives that they would never have again.
The purpose of clinical research is to help understand how the human body works and how health and disease come about. So we want to understand what makes good health.
I think women's participation in clinical trials is extremely important because we have an entirely different set of issues, whatever body system you're working with, it's different from a man and from a child. So there are certainly differences there that we need to understand and focus and realize that are specific to women.
Science has shown and taught us that men and women are different in a variety of ways beyond the obvious differences. Our organs are different, our level of our hormones are different, we respond to treatments and medications differently. Based on those findings, every single cell in a woman or a man's body is a male or a female cell, and those cells respond differently to different triggers, to different treatments, and to the environment.
C stands for courage, collaboration, compassion, and sometimes even cuddly. At Miami Cancer Institute, C also stands for Cure, world-class cancer care, right here at home. Learn more at miamicancerinstitute.com.
Welcome back to the Health Channel, all health, all the time. I'm Kathy Buccio. Today we're talking about breast cancer with Dr. Victor Guardiola, medical oncologist at the Miami Cancer Institute. If you have a question for the doctor, please call in using the toll-free number, 855-796-4475. We'd love to hear from you. Now we're also joined by one of Dr. Guardiola's patients, Clara Pablo. Welcome, and thank you for joining us on the show, Clara.
Hello.
Cannot wait
Hi.
to hear your story
Thank
and
you.
share your inspirational journey.
Thank you for having me.
So I understand you were diagnosed with cancer when you were 36 years old.
Mhm.
Again, we were talking about this is less than 40. How did you get diagnosed?
I got diagnosed, because I felt my own lump. I felt the lump myself. I was at home watching television and I went to scratch my breast and I felt something that felt like a silicone ball. I freaked out. I called my gynecologist at that time, and he said, "Come on in and I want to touch it, and check it myself." So I did the next day, and then he sent me to get a mammogram and an ultrasound. And in the ultrasound, I could physically see it in the ultrasound.
So there was
like
an
in
actual...
the screen, you could see that there was a mass. The mammogram you don't see it, but in the ultrasound you could really see it. And then, the lady left. I saw the change in her face. I knew something was wrong, and then when she came in with the doctor, that's when I knew something was really wrong.
What was your reaction when you heard?
Immediately they tell you we need to do a biopsy, so I'm like, let's do it right away. And then, I asked her nonchalant, like, oh, it's probably a cyst, right? And then she looks at me and she's like, no, it's not a cyst. It's a tumor, and in my experience, it's probably cancer.
Right.
I didn't wake up that morning thinking I was going to be diagnosed with breast cancer. The longest 24 hours of my life waiting for the results to come back, and when the doctor calls you in, my doctor called me in the next day at 11:03 a.m. and he's like, hey,
So you never forget that phone? You never forget that phone call?
Never forget that phone call. And he's like, hey, I got some bad news. And the results came back and it's positive. And I remember sitting on my couch by myself, and like the whole world just fell on me, and it was everything after I grabbed my computer and I started Googling it on the phone with him, and the words after cancer just became a blur, and I hung up the phone and I was like, how am I going to call my family and tell them that this is going on?
And one of the first phone calls you made, we were looking at your video, was you called your mom.
Yeah, I called my mom. I actually called my mom to be with me at the biopsy the night before. I don't know, us Hispanic women, parents, they freak out. So I didn't call her before when I found something, because I didn't want to scare her. I wanted to be like, oh, I just had a cyst, it's fine. But when they told me I needed to get a biopsy done, I had to call her. And
do you have a history of breast cancer in your family?
Yeah, I have two aunts that had breast cancer on my mother's side. So I always checked myself. I was always very active about checking myself. So I think that family history does play a huge role in
And
all
it
of
does,
this.
right, Dr. Guardiola, the family history?
Yes, as we were talking earlier, it's not only about genetic testing, it's taking in consideration family history as well, and personal history.
Now, I want to go into your treatment because I understand, Dr. Guardiola, that in her case, she did not need the chemotherapy.
Yes.
But what did you undergo?
So the first thing that we did was we had to wait for the biopsy results to come back so we see what kind of tumor it was. And then we needed to see if it was HER2 positive or negative. That's the first type of, apparently you need like a specific chemo if it's HER2 positive or HER2 negative.
Yes.
So that was one thing that we're like, okay, you don't need this specific chemo. So I was like, okay, one down.
Okay.
Then I had to get a lumpectomy and my lymph nodes removed. When they removed the tumor, they did like, they checked for the tumor markers. They were clear, so they didn't spread. My lymph nodes were negative, so that's a good thing.
That's great.
And then what they do is that they get the tumor and they slice it, and then they check every layer of it. And then based on the number that comes back, that number, look at me, I'm such an expert.
I was going to say,
Yeah,
my med student
my teacher over here.
Student.
Based on the number that comes back, it depends on whether you need a chemo or not. My number was low versus, like a middle ground or a higher number, which means your recurrence score. Mine was 17, I believe. I think 19 is the border.
So depending on the newer data, we're using different cutoffs. I think yours was, I don't recall, 16 or 17,
Yeah,
very low number.
Low.
so
And
her number was low.
Yeah.
Yes, so pitching in on that is that if she would have seen me in the era before we had this testing available of actually test genetically the tumor, we're talking now a different genetics, we're talking the genomic profiling of the tumor. We did not have that technique available for many years, and so back in the day, you were using other tools to determine who was needing chemotherapy or not. And arguably, if she would have seen me a few years back when we didn't have this technique, I probably would have had to offer her chemotherapy by virtue of the tumor size, which was not significantly large, but large enough to consider it. And luckily enough, nowadays we were able to prove that hers was necessarily slightly large, so in the category of slightly big but fluffy. So in other words, non-aggressive, for which I think we avoided, obviously, the treatments that carries the most side effects,
So
which sometimes are needed, but in her
Ryan,
case.
so thankful for those advances. We have a photo of you actually getting treatment. You were, I believe, receiving radiation.
Yeah.
And this is the form of treatment that you...
That's me. Yeah, so that's the day that they actually mark your body to make sure that, every day you come in and it's a very quick process. And that's exactly where the marks are. That's where the layers, the lasers shoot you through.
And that's where it's administered, correct, doctor?
Yeah.
Yes. So radiation treatment is obviously is a must in a patient that has preserved her breast and has a diagnosis of invasive breast cancer, like in the case of Clara. There was no advantage of doing a mastectomy, so here we're pitching on the topic of double mastectomy.
Right.
Did she really needed that? And probably the answer to that, is no. And I think she chose wisely and decided to do breast conserving technique on the affected breast, not doing anything on the contralateral breast, more so and continue with the screening. And for that, we needed radiation to actually make it happen.
And Clara, what was treatment like for you? What was it difficult? I mean, not just physically, but mentally, emotionally. How did you get through that process?
It was draining physically and mentally. I mean, one of the things that I want to add is that the reason why I also chose the lumpectomy is because my BRCA came back negative. Had my BRCA came back positive, that would have been a huge factor in the fact that I would have gotten a double mastectomy.
Yes.
And going back to your question, it was very draining, going into the hospital every single day for 30 days in a row. Get to be very draining. And then the actual radiation, you don't feel anything while you're laying down there, but the rest of the day I felt my right breast cooking. I mean, one day I got a thermometer and I put a thermometer on the left breast versus the right breast, and the right breast was 8 degrees hotter than the left.
Oh my goodness.
And it burned and it was uncomfortable. And it just physically, completely just drained you. I was tired all the time. And then when I was on tamoxifen, the first 3 months, I would fall asleep right here, talking to you. It was very, very draining. But, it wasn't compared to, I feel like, the chemo or anything else. It wasn't so bad in hindsight of it all. The fertility treatment was also something that was pretty tedious, but I thought it was something that was very important that I needed to do because it prepared me mentally for, I unconsciously telling myself that I was going to have a future. So
right.
that was very important to me.
That's what we're going to talk about, not because when you're going through treatment for breast cancer and you're under the age of 40, the topic of infertility comes up.
Yeah.
I'm sure you see that with your patients as well. And we're going to dive into the topic of preserving the fertility later in the show, but you wanted to preserve your fertility so you can have children in the future. So what route did you choose? What did you do?
For fertility? It was a very tough decision to honestly to do the fertility treatment, because in my head, I'm not a doctor, but in my head, you know, if my tumor was hormone receptive, why am I going to be injecting myself with tumors? And I actually bothered him so much about this topic, because, you know, when they made you sign a paper saying, hey, radiation and the treatment you're doing is going to affect your fertility, it kind of makes you think about
your future.
Okay, you know, but one of the things that I kept telling my parents is like, I want to be alive to have these children that you want me to have. So let me first treat myself, and then we can think about fertility. Right. But when the time came, I had to really sit down and think about it. And I'm very glad I did it, because it removed that whole, you know, weight off my shoulders, because I can't even think about having children for the next 5 years, because I'm in active treatment for the next 5 years.
Right.
So, you know, and then I'm old. The older you get, your eggs just become not as viable. So
right.
We kind of stopped it. You know, we kind of put a stop to that so that I can continue to focus on my health and getting 100%, you know, cured, so that later on I can just continue living my life.
And we're going to get into more detail, but I do want to ask you, Dr. Guardiola, did your treatment plan change with Clara once she underwent, knowing that, yes, fertility was something that she wanted to discuss further?
Yeah, so obviously we have to take in consideration in a young female that wants to carry, with fertility later on, that when you intersect that, it's a fine balance in between doing it and doing it safely. As you mentioned, you always want to preserve your life in order to be present for that potential future children. So the bottom line is, yes, it changed a little bit, but that's the reason why I think it's very important to have a multidisciplinary approach to this. That's the reason why, you know, it's important for any breast cancer patient to actually be treated in a state-of-the-art center where you can have genetic counselors, you can have, you know, fertilization specialists, you can have your surgeon, your medical oncologist, your radiation oncologist, and we can design a plan.
Open communication between everyone.
Open, because one of the biggest mistakes that we've seen is rushing into decisions, right? So I got a breast cancer, I got to get it all out right now, which arguably might be okay for the vast majority of patients, but not necessarily for all. So I think, dress me slowly, that Amon Harris, it applies here. So the first thing is to, we have to help you in like thinking of these things, because obviously, I'm not sure, Clara, how much that crosses her head when she heard the word, you have cancer, you have to deal with this. Probably was the last thing that she heard about.
It was.
But it's our duty to actually bring that up, because we don't want to miss the opportunity to be,
something was taken from her in that sense.
Absolutely.
Now, coming up, we briefly touched upon the importance of fertility preservation for women under the age of 40 who are diagnosed with breast cancer. And we're going to hear more specifics from Clara and her experience with fertility preservation, so stick around. You're watching the Health Channel, all health, all the time, on South Florida PBS. If you have a question for the doctor or for Clara, you can call in using the toll-free number 855-796-4475. And please be sure to visit our website, allhealthtv.com, where you can watch videos from previous episodes or submit questions for the experts. We'll be right back.
Hurricane Florence made a direct hit on the Carolinas, causing wind damage and widespread flooding. As the floodwaters begin to recede, Allstate mobile claim centers are canvassing the Carolinas to assist people affected by the storm.
We have mobile claim centers set up throughout the entire area so that people can come to us and they can start the paperwork. And in some cases, if they have a covered loss, we can cut them a check on the spot or deposit money into their accounts.
Learn more at allstate.com/recovery.
Welcome back to the Health Channel, all health, all the time. I'm Kathy Buccio. This hour, we're talking about breast cancer with Dr. Victor Guardiola, medical oncologist at the Miami Cancer Institute. If you have a question for the doctor, please call in using the toll-free number, 855-796-4475. We'd love to hear from you. Now, we're also joined by one of Dr. Guardiola's patients, Clara Pablo. She was diagnosed with an invasive ductal carcinoma at the age of 36. And as a young woman, Clara was faced with many decisions, including whether to take her steps to preserve her fertility. So, Doc, let's start with you. How common is it for women to be concerned with this and take steps to preserve their fertility?
So it is somewhat common, although again, I go back down, particularly in breast cancer, to the statistics. It's only less than 5% of the patients are less than 40 years of age. And the vast majority already have a planned, a child and a planned family already. So even younger females, a great proportion of them have had kids already, and when they face this, they decided not to do it. But it still is a substantial amount of patients. Obviously, in the pediatric population, if we expand this to other cancers, it is way much more common. No? And so, but yes, nowadays we're seeing it more and more. There's more awareness about the topic, and I think it's a very important one, particularly in a young female that has not gotten the child.
Very important. Now, let's take a look at some of the different cancer treatments. So can you tell us how these cancer treatments affect fertility individually?
So yes, so again, these are the types of cancer treatment as a general terminology. What it means for, let's say, breast cancer care is surgery to the breast. It won't create a problem as far as infertility. And so chemotherapy for sure, in the sense that it can, the medications that we use for chemotherapy can affect the ovaries in the sense of, killing the eggs. Remember that females are born with the same amount of eggs that they carry throughout their life. It's just that they get to be mature. So there's not a replacement of them after chemotherapy. That doesn't mean that every single chemotherapy agent will do it. That doesn't mean that everyone that gets exposed to chemotherapy will happen. Radiation, the same applies. Although
which is what, in Clara's case, she had radiation.
Absolutely. We feel very safe about that component, despite the fact that we did in vitro fertilization, that radiation to the chest wall area should have less impact on, like compared to, for example, radiation to the pelvis. Whenever we use radiation to the pelvis, and radiation again is a technique that is very localized. So we're doing radiation to the breast, we're focusing on this area right here. But when we're doing radiation to the pelvis, let's say for cervical cancer, that's a topic that becomes way much more important. And then obviously anti-hormonal therapy, when we are trying to lower the estrogen, that has, for example, tamoxifen, which is one common medication used to prevent recurrence of breast cancer, has teratogenic effects on babies, so birth effects on babies. So we cannot safely try to get pregnant while on these medications are going.
Now, does the length of treatment also affect the fertility?
Yeah. So as a length of treatment, I think we can go into like the amount of treatment. Right. So the more treatment you get, the more likelihood are you to develop infertility secondary to that. And then even if you haven't gotten infertility from some of these treatments immediately, you can get into early menopause, which is another problem, right? And sometimes, a young person gets in to prove that she still is fertile right after finishing treatments, but then the ovarian function ceases afterwards, and then you wrongfully assume that you're going to be able to become fertile after passing that first step. So it is important not to assume that fertility is going to be preserved in all comers. Even if you're doing the minimal amount of treatment, like in the case of Clara, we haven't done the strongest one towards impairing fertility, which is chemotherapy, but we're currently doing anti-hormonals, and we have done other things.
And we're going to get into that a little more. Now, for Clara, preserving her eggs gave her motivation and a reason to look forward to the future. Let's take a look, and we'll talk about it on the other side.
When you hear the word cancer, you don't think you're going to have a future, So one of the things that all my doctors kept repeating is, get the lumpectomy with reconstruction because you're going to have a future. Make sure you look okay, Let's preserve your eggs for the future. It makes you think that just the thought of that, it gives you something to look forward to. I chose to go ahead and freeze my eggs. The process for fertility preservation is a bit tedious. You have to inject your abdomen for about 14 days. So, there were times, I'm not gonna lie, where I was like, is this worth it? Like, do I want to continue putting myself through this when I've already been through so much and I'm gonna keep going through so much more? And once I was done, I said, okay, let's keep worrying about my treatment and what I need to be doing to make sure that I get to use these eggs in the future. I'm gonna be around for a very long time, and I want to do a lot. I want to travel the world with work, but I also want to travel the world speaking about breast cancer awareness.
I'm always so thankful when people come and share their stories, and I'm really thankful that you're sharing yours. So talk about your decision to preserve your eggs, because like you mentioned, it's not just for mommy and papi anymore.
Yeah,
you did it for yourself.
Yeah.
What made you go that route?
When they told me that I had to sign that paper saying that my fertility could be affected, it's just kind of like when they tell you you can't do something and you want to.
Right. Was your ha-ha moment?
I was like, oh wait, you're telling me that I really probably don't have that choice. When they had the possibility of taking that choice away from me, that's when I said, all right, I'm really going to sit down with my doctors and figure out what the game plan's going to be.
Right.
And I did. I sat with Dr. Guardiola many times. I think he was annoyed with me at some point. And you know, I went to see many doctors, and I liked the fact that and at MCI that all the doctors, they spoke to each other, and all of my doctors, every single one of them, I needed to get a green light from all of them.
Right.
And I did, and my fertility specialist was in constant communication with Dr. Guardiola, which I thought was very important, you know, just to keep that peace of mind at all times. And
were you even thinking about kids before you got diagnosed, or not even on your radar?
No. I mean, at 36, I mean, I don't know, my friends and I travel a lot for work, and I have a very fast-paced life, so kids was not even an option. I was like, eventually I'll think about it, maybe.
Right. And this sort of just...
This really just made me have to stop and think about, is this something that I want for my future?
Right.
I mean, and I have the option. I don't know if I'm going to use it or not, but just the fact that I have it there, that really was a peace of mind. And like I said in the video, subconsciously, I didn't even think about it. I was preparing for a future, you know? Because when you think about, when they tell you have breast cancer, or when they tell you have any type of cancer, you don't think you're going to have one. So this kind of subconsciously reminded me every single day that I was planning for the future that I was going to have eventually.
Now, you mentioned in the video that you actually froze your eggs, but doctor, there are quite a few other ways to preserve fertility treatments without having to freeze. So you walk us through them. We have a graphic showing some of these.
Yeah. So yes, obviously she chose the second option that we see on the screen. First option is similar in the sense that we preserve the embryo. So this is when you already know, you know, the sperm donor who's going to be, whether it's your husband, boyfriend, and you're 100% sure you want to preserve you know, a fecunded egg already, a fertilized egg, then you choose to do embryo preservation. You can do a combination. You can preserve eggs, which is, you know, without a sperm fertilization, or you can preserve embryos. And then you can do, in case that we use radiation to the pelvis, as I mentioned before, for example, in gynecological cancers, you can do gonadal shielding, or you can do something called ovarian transposition, where we actually surgically move the ovaries away from the treatment field.
Okay.
Again, thinking about local radiation is a focal radiation.
So
that
the ovary is not affected.
Exactly. So we remove it on the field, and then in case, like, for example, in cervical cancer, the fifth option right there, which is removal of the cervix without necessarily having to remove the whole uterus. So that will allow us to potentially implant an embryo in a uterus without having a cervix that needed to be removed surgically. That's called trachelectomy, let's say for the treatment of cervical cancer, without the need to remove the whole uterus and pretty much cease the option of fertility for that person. So, and then you do C-section, and you can go through a viable pregnancy after that. So.
Now, Claudia, in that video we watched, you mentioned that there were times that you felt like giving up in the process. You asked yourself, why am I doing this? What encouraged you to keep going?
Honestly, it was just like, I'm already halfway through. Let's finish it. Let's keep going. Let's really be able to just. I kept seeing the finish line, and I was like, every day just kept closer and closer and closer.
But in these videos, I'm seeing your friends, and you're sharing the experience, which you shared your experience with all your followers, which I think is so raw and so brave. So was this part of that motivation?
Yeah, I mean, my friends and my family and even my boyfriend was there injecting me every day, and that helped a lot. You know, they kind of like helped me. You know, towards the end, it was just, it went from 1 injection a day to like 3 or 4, and then my abdomen was swollen, and every day I had to go get blood taken out, and I can only get blood drawn from one arm because I had my lymph nodes removed. So my left arm was just raw. I mean, it was, I didn't even know where they were gonna get, I think they were already taking blood out from here because it was just so raw. So it was very grueling, but like I said, my friends and family helped a lot, and I saw the finish line, and I just wanted to get through it and just.
How are you feeling now?
I'm good. I'm doing very well. you know, one of the things that we go back and forth with is I'm on treatment. So every day I take a pill, anastrozole. I started with tamoxifen, but now it's anastrozole. I'm going to do that for the next 5 years. And then every 28 days I get blood drawn and he checks my levels and I get an injection called Zoladex.
So Clara's currently on treatment still. You are
for the next 5 years.
For the next 5 years.
Yeah.
So this treatment, not necessarily obviously because she has active cancer. This part of the prevention is to maintain lower estrogen levels in her body, and arguably one of the reasons while she's undergoing this is in theory infertile or she's going to have difficulty to conceive. So that's the whole idea behind egg preservation, because by the time we will be done, at least with the first approach, we're approaching an age that probably you can get into problems with fertility anyhow, naturally speaking. So I think, again, going back to the topic of fertility preservation, I think you not only have to think about the right time, but you have to sort of think about the whole length of the treatment, the duration of the prevention, and plot that into obviously the patient's wishes and calculations of a statistical risk and determine your course of action. But yes, currently we're doing this double intervention of blocking her ovaries and taking a pill to block estrogen production from another source to pretty much bring estrogenic levels to the minimum.
Now we have a video of you ringing that victory bell, so let's take a look. Oh, what's your reaction when you see this?
This course is run. I'm on my way.
Yeah!
Wow.
I feel like you make me cry too. I have to give, I feel like I have to clap. It's like, it's amazing. How rewarding is that? How did that feel?
I mean, from day one, I remember I was sitting one time in the waiting room because I had to go to the hospital every day for treatment, and I heard a bell and I heard a lot of people clapping, and I asked somebody that was with me, I was, what is that? What is that bell situation? And they're like, oh no, when you're done with radiation, you're gonna ring that bell. So to me, it was like, I really wanted to ring that bell. Yeah. So, when you go every day, you pass it. I'm always like, I'm gonna ring you one day, I'm gonna ring you soon.
Like, I see you, Bell.
I see you, I got you. And, it was so rewarding to on that day, my family, my friends, I mean, I had a huge, posse with me.
Of course, we got to.
And I pretty much, every person that I talked to at MCI was actually there as well.
It's amazing.
My doctors, my nurses, they were all there, and it was such an amazing moment. Because when you ring that bell, you're like, wow, I did it. Like,
it's almost like a sigh of relief.
Like a sigh of relief that, the worst is over, and you can starting to live your life again. And it was just such a moment, like a historic moment for me, so special.
Dr. Guardiola, when you see the patients ring that victory bell, what does it mean for you?
I mean, it's hard to explain. Obviously, it's like, you feel like the patient has accomplished what you want for everyone, which is, a success story, the fact that you're cancer-free. So it signifies for us providers, I think, and I probably speak for all of us as a group, it signifies that, all the efforts in like training yourself to become a provider to do this for the good of the patient. I mean, this is our signal that we did it, so. But I think it's very important, particularly for Clara. We're talking about her being on treatment, but that bell signifies the worst is over, meaning her surgery is over, her radiation is over. Now we're just doing this treatment just for be super secure and be in a preventive mode, no? So I think it's
the
great.
big hump.
Yeah.
Absolutely.
Rewarding. Yeah. Now coming up, with the rise of social media over the last decade, the internet has really changed and has even served as a key tool in raising breast cancer awareness. We're going to talk about Clara's social media campaign when we return, as well as the importance of breast cancer advocacy. So don't go anywhere. You're watching the Health Channel. All health, all the time on South Florida PBS. If you have a question for the doctor or Clara, please call in using the toll-free number 855-796-4475. And please be sure to visit our website, allhealthtv.com, where you can watch videos from previous episodes or submit questions for the experts. Don't go anywhere.
You have heard about breast cancer, but do you know BRCA? BRCA stands for Breast Cancer Susceptibility Gene. Everyone has BRCA genes, but some women inherit BRCA genes that have a mutation or a change. Women with this genetic change have a greater chance of developing breast and ovarian cancer than other women. about 50 out of 100 women with a BRCA1 or BRCA2 genetic change will get breast cancer by the age of 70. CDC offers a confidential web tool called Know BRCA that women can use to learn their risk of having a BRCA gene mutation.
Learning your risk for a BRCA gene mutation allows you and your doctor to make important decisions for your health. This may include genetic counseling and testing, enhanced screening, and other methods to reduce your risk of ever developing breast or ovarian cancer.
Enter your family history, learn your risk, talk to your doctor. Visit knowbrca.org to find out more.
Hi, I'm Janelle Hale, founder and CEO of the National Breast Cancer Foundation. No one should face breast cancer alone. When I was diagnosed 36 years ago, there was no internet, and I had to make a decision with little information. Early detection saved my life. It could save yours too. To learn what every woman needs to know about breast cancer, visit nbcf.org/hope.
Welcome back to the Health Channel, all health, all the time. I'm Kathy Buccio. This hour, we're talking about breast cancer with Dr. Victor Guardiola, medical oncologist at the Miami Cancer Institute. If you have a question for the doctor, call in using the toll-free number, 855-796-4475. We'd love to hear from you. Now, we're also joined by one of Dr. Guardiola's patients, Clara Pablo, who after beating breast cancer has not only become an advocate for other women today, but also a social media influencer in the fight against breast cancer. So tell us about your campaign, and it's called Te Toca Tocarte.
Yeah. It's
your turn to touch yourself.
Yeah.
So tell me a little about the campaign, how it started.
So, you know, when I got diagnosed, it was very difficult to find somebody that I could relate to, under 40, Latina, because, you know, in the Hispanic community, it's not something that we talk about on a daily basis.
Right.
So, you know, it was very tough for me to try to connect with somebody and to see what was going to happen to me, or to connect with somebody to see how to feel, if I was feeling was normal. So to me, it was very important to have that, you know. So when I found that there was really nobody that I could relate to, I decided to just figure out, I was like, I'm just gonna start doing it myself and start talking about it myself. Throughout that process, I started researching, and I found many, you know, women that were going through the same thing, you know, and we just started connecting. And I noticed that there were so many women that were under 40 that had breast cancer. You know, by me going public with my situation, friends of mine or colleagues of mine approached me and telling me that they had gone through breast cancer, but they didn't talk about it. So to me, that was mind-blowing. So that's when, so that's when I was like, I'm really gonna go out and make it my journey public. And I was very open about, you know, my treatments, I cried on camera about how scared I was about certain things, and my you know, it was a celebration, and everything was shared, and from my burnt breast to my fertility preservation, and all of that was incredible to find this community. So because of that, I found this campaign that was done in the English American market called Feel It on the First, and I loved the thought of that. It was every month, the first of every month, you know, we talk about this. So I decided to mimic it and do it for the Hispanic community. And, you know, sitting down in my office one day, I said, the idea just came to my head, and it said, Te Toca Tocarte. It's such a catchy phrase.
Yes.
And I was like, that's it. I'm gonna call it Te Toca Tocarte. So it's, you know, the first of every month, I put a picture, you know, as you can see there, with my hand over my breast, and I tagged 2 more women. And, you know, because of what I do, I have a lot of friends that have a lot of followers. So they tagged 2 more women, and in turn, they tagged 2 more women. So every month, we're talking about a subject that's been so taboo for the Hispanic community, and we're talking about it. And it's crazy to me that so many women have reached out to me telling me, hey, I checked myself and I found the lump. It's a cyst. It wasn't anything. Or unfortunately, hey, I checked myself and it was cancer, but they found it at an early age. And that makes a huge difference. So apart from the fact that we're talking about breast cancer awareness and we're making it a subject that's not taboo, it's saving people's lives. And that to me
and
is
it's motivating you to keep going and doing this.
100%. I mean, and I feel like, you know, cancer has been such an awful, horrible experience, but it actually helped me find my voice, and it helped me say, you know, like, one of the things that I realized that if my journey and everything that I've gone through can save one person's life, or help one person feel like they're not alone, then honestly,
Your
it
work
was
is-
worth it. It really was.
Now let's take a look at the program that you created, Te Toca Tocarte. You stress that your health is literally in your hands, and you're your best advocate. Let's take a look.
So I created this campaign called Te Toca Tocarte. It's for Hispanic women. It's a monthly reminder for women to check themselves. The slogan is, your health is in your hands. It really is. It's in your hands. If we check ourselves, we can be the first advocates. Nobody can advocate for ourselves and our health more than we do. I felt the love. And the same amount of energy that I'm dedicating to my work life, I'm dedicating it to breast cancer awareness. That's why I will talk to whoever will listen.
You're so right. It has that catchiness, Te Toca Tocarte.
Yeah.
It's like, yeah, I want to do this. Doctor, how important was her attitude? I mean, yes, amazing work that she's doing. She's a survivor, but that determination, that positive attitude had to be an asset in her case.
Absolutely. I think, at least I can speak, one example is, for example, the treatments that we offer, particularly chemotherapy. When we get down to that, the attitude even impacts on side effects. So you wouldn't believe it. It's like if your attitude is not the right one, you're more likely to get more nausea, more tiredness, more symptoms. So the mindset, I think I'm a great believer, although again, it's hard to prove it scientifically how that impacts or whatnot. But I think, when you see the right mindset, I think it makes you, a completely different person, a completely different patient. The way she handled the situation, the way she took it, I think is an example, and I'm grateful that she's able to express it. And so, it's hard to be in a patient's shoes, no question. And it's not at a faultiness of everyone if that attitude is not there. But if someone can help you achieve that, for me, it moved mountains.
So now, anyone can join the movement, and we just hashtag?
Hashtag Te Toca Tocarte.
So where we take a photo?
So the first of every month, you take a picture and with your hand over your breast, and then you just remind, hey women, don't forget, you gotta check yourself. It's so important, because especially for women under 40, the doctors don't tell us go get a mammogram until you're 40. So what if I would have waited till I was 40 years old to get a mammogram? God knows how big my tumor would have been, or if I would have even be here talking to you guys. So it's so important to just talk about it. So yeah, just post it and then tag 2 more women, 2 more friends, and then they'll tag the rest, and then the rest, and the rest, and the rest.
I'm gonna do that. Now, more big things for you, because you have a partnership with the National Breast Cancer Foundation. And you're actually one of the first Hispanic women to be in their campaign as well. Is this true?
So I partnered up with the National Breast Cancer Foundation. We're doing an active campaign where, we're raising money to give away free mammograms. So, that's so incredible to me, because again, in the Hispanic community, there's so many things about, insurance and documentation. So it's very important when health insurance it's not cheap. So, to be able to give away free mammograms for women that can't afford it, that is so special.
It's so special. And to see the rewards, bringing this kind of awareness, you see that in women?
Yeah. Of course, and it's so touching when women tag me when they're getting mammograms. To me, it's just amazing to see that. It's like, wow, you got a mammogram because I told you to.
Yeah.
That's amazing.
You're like, thank you for listening to me.
Thank you so much for listening to me. I'm not talking to the air.
And I know we just had a picture of you in front of our Baptist breast cancer awareness truck.
My face is on a truck. How crazy
Your
is
face is on a truck. You're like, I made it, Mom. I made it.
Look, Carrie Bradshaw moment.
Thank you guys so much for being on the show and for sharing your story, Clara. It has been such an inspiration having you on as well. And that will do it for today. Make sure to follow us on Instagram, Facebook, Twitter at AllHealthTV, hashtag AllHealthTV. And you can also go on our website, allhealthtv.com, where you can submit questions for the experts or watch videos from previous episodes. There's so much you can do on our website. Thank you for joining us.